I will discuss for imaging, but also for the metabolic follow-up, because we do it together in the guidelines. It doesn't work, I'm afraid. So I have no conflict of interest, and you all know that following up our patients is the mainstay after conservative or invasive treatment for our patients. Why is this? Because we want to prevent recurrence and growth of a residual stone, and also to detect a recurrence early and possibly to treat the recurrence. How do we prevent? By following up our patients in a metabolical way. And how do we detect? By using imaging. Now, when we started about discussing regarding the follow-up in the guidelines, we had a lot of questions, and I think in your everyday practice you have the same questions. If you do believe that I will give you answers for all these questions, you fool yourselves, because we don't have it in the literature. Why is it the diversity of the stones? Yes, but also for many other reasons, because it depends how the urologist or the physicians follow up their patients, depends on many factors. Depends if they were trained or not, the resource limitations, and also the fear they have about the radiation exposure. And you all know that radiation is very important, and I'm really being affected from radiation myself. So if you use either ultra low dose CT scan to follow up your patient is exposed to radiation. And if you see what is going on the first 2 years after stone treatment, they overpass the threshold of 50 millisieverts a great amount of patients during their follow-up for stones. I would like to remind you here very quickly regarding the metabolic follow-up that we do it approximately for 25% of our patients who are at high risk for stone recurrence. How do we define the high risk? In the guidelines, several groups. Let's say if you have a child, he's at high risk in his or her lifetime to have a stone recurrence. If you have a cystinouric patient, or if you have hyperparathyroidism, and if you have some anatomical abnormalities, and I think this is very well established within the guidelines. Now, until now, how often we follow up our patients? And most of people, they do it twice from the literature. And they alternate, actually, US and CT scan. And I will give you what we propose in the guidelines. And John Dunstan, if you see from the same study, the timing of the follow-up should be individualized on the patient need and also on what the physician, the urologist actually, or the nephrologist thinks is the patient's need. What we have done in our group, in the guidelines, we performed a systematic review and a meta-analysis of the literature to see how is the best way to follow up our patients and the timing, both metabolically and with imaging. And you see from just, don't see the screen, we have the best evidence for approximately 2 to 3 years of following up. Then we skip in the literature, we have no evidence, and we go up to 5 and 10 years. But the evidence at 5 and 10 years is very low. So what we know, we had to divide in separate groups our patients. Otherwise, the systematic review was of no meaning. And we had the stone-free patients, but we had the patients with fragments less or equal to 4 millimeters. Why 4 millimeters? Because we know as urologists in the literature that we may have a significant residual fragment less than 2 millimeters. But yes, we have some studies, but if you summarize the studies, they are not enough to have a lower cutoff limit. So we know that approximately 30% of these patients may have an intervention at 2.5 years, which actually drops the intervention rate after that to 20%. As we define the disease progression in the systematic analysis, meaning growth of residual or becoming symptomatic or a new stone formation, we have poor evidence, but the disease progression, it was approximately 20% at 20 months and 34% at 35 to 49 months. On the contrary, spontaneous passage rates for these small fragments was 34% very early, but after that point, we don't have enough evidence. We did, as I said, meta-analysis for those patients with fragments more than 4 millimeters. Very limited evidence. Throughout the time points that we looked at, we had high reintervention rates. And we believe that if you take this into consideration together with the small rates of spontaneous passage, you should probably intervene, as I will show you in 1 minute, for these patients. Now, for the high-risk group patients, that was the third category of the third group that we looked at. And the high risk was defined, as I showed you in the earlier slide. We saw that for those patients that they were sticked on their medication during their follow-up, although we had very limited evidence, up to 2 to 3 years after the stone treatment, they were stone-free in a rate of 74%. Those patients at high risk that they were not taking their medications, the high risk rate, the stone-free rate was very low, the recurrence rate was very high. And, sorry, this is the same slide. So we came with a conclusion that you will find at this version of the EAU guidelines this year. If you have a stone-free patient, then if you discharge the patient at 2 years' time, you have a safety of up to 80% that the patient won't come back to you. If you want higher safety, up to 90%, then you may still follow this patient up for 5 years. How? Alternating US and KUB, and I will discuss the algorithm in 1 minute. If the patient has residual fragments less than 4 millimeter or dust, for dust actually we found only one study. That's why I don't discuss it further. So if we have less than or equal 4 millimeters, then we have to follow up for 4 years or intervene when the patient becomes symptomatic or the stone is becoming larger. If it is more than 4 millimeter, we do believe that reintervention should be the case for these patients. For high-risk stone patients, you can see that for those on medical treatment and that they are strict with their medication, then we may consider discharge these patients. For those high-risk patients that they are not compatible with taking the medication, we should follow them up. And after doing the systematic review, we sat together and we had a panel consensus on how we should follow up and how often we should do it. And this is a panel consensus. I remind you that the panel consensus level of evidence is very low, so it's open for criticism, but I think it is the best we could do with the evidence we have as urologists. So, follow-up after treatment. If it is stone-free, then, and is in the general population, not at high risk, probably at 6 and 12 months, do imaging. Imaging means ultrasound plus or minus KUB. I will discuss about the CT scan. And after that, for 36 months, you may counsel the patient on continuing the imaging or discharging the patient. If it is at high risk, you should do imaging and metabolic and treatment monitoring, because the follow-up also has a branch that you should monitor the side effects of the treatment that you give, and you should do it up to 6 months, as we said. Probably you may have to skip. You do it twice the first year and then annually. If you have a patient with residual fragments, and the fragments are less or equal to 4 millimeters, but the patient belongs to the high-risk group, then you should follow as the high-risk group itself. If they do belong in the low risk, then you have imaging twice the first year and then annually. And imaging still is ultrasound and KUB. If you have residual fragments more than 4 millimeters, you should do all the way through imaging. And imaging still is ultrasound or KUB. There is an asterisk for this table. We recommend for those patients first intervention. If on an individual patient you consider that you should not intervene for any reason, then imaging is highly recommended. Last but not least, for following up our patients after definitive treatment, we do not recommend CT scan anymore. We do recommend CT scan, though, this is another asterisk, if we think that we have to re-intervene for any reason. So, thank you very much for your attention.